This is a brief video about rotator cuff problems. The rotator cuff, this is a right shoulder as if it was sitting on me. The rotator cuff is made up of four muscles: the subscap, the supraspinatus, the infraspinatus, and the teres minor. And these four muscles come together around the shoulder and therefore make a bit of a cuff, hence the rotator cuff. And they're involved with movement of the shoulder, rotating and moving and elevating, but also involved in holding the ball of the shoulder in the socket while the other big muscles around the shoulder are able to move it more. Problems with the rotator cuff are clearly related to age, so that we see people in their 20s or 30s and a significant rotator cuff injury is very uncommon. Whereas we see people in their later 50s, 60s, 70s, and rotator cuff problems are very common. Rotator cuff problems come on most of the time in a slow fashion, maybe without a specific injury. Occasionally, maybe the shoulder was going along with a little bit of pain and then something seems to make it worse. On a few occasions, it comes with an absolute trauma. Fall skiing, going off a mountain bike, something like that, where someone has a complete change in their shoulder function. But for the most part, we're dealing with people that have had this going on over a period of time. When people do have rotator cuff problems and they have pain in the shoulder, a good bit of the time, the pain is in this area over the deltoid muscle that we'll say is on this lateral side of the shoulder. They have pain at night. You almost can't have a rotator cuff problem if you don't have some night pain. They have pain with significant overhead activity, can be associated with repetitive activity, such as in an occupation, or even repetitive activity with a sport. It's also important that the shoulder sometimes feels weak. Now, that can be actual weakness, that the shoulder literally can't be lifted up or put in certain positions, or it can appear to be weak because of pain, and the pain really limits someone's ability to use the shoulder. When someone presents with a rotator cuff problem, we obviously are interested in the history of how this has come on for them. And on an exam, we're looking for things that are what we would call provocative maneuvers, those things that cause pain and symptoms. We're also looking at strength and also how they hold their shoulder, their position, and their posture. But important to us also would be how they look on X-ray or radiographic analysis. In an early evaluation of rotator cuff problems, if we make that diagnosis, we would start for most patients conservatively, and we would say some therapy, be it at home or organized physical therapy, maybe some non-steroidal anti-inflammatory treatments, some activity modification, maybe decreasing some of those activities that can cause stress or pain. It's not uncommon for us to consider an injection in the shoulder. Part of this is to say, can we take away some pain and then have you feel stronger or more able to move the shoulder? And sometimes with a steroid as part of the injection, there's actually a therapeutic effect where we decrease some inflammation and perhaps allow it so that you can exercise better or respond to physical therapy better. It's important to note that a large percentage of rotator cuff problems we manage conservatively and get patients back to what they want to do without any specific intervention such as surgery. One of the major things we look at, particularly in younger patients, 40, 50 years old, is real, true, legitimate weakness. And so if we can take away some of the pain and patients are really weak, then that makes us concerned about a significant rotator cuff tear. And then clearly those patients that we have tried conservative management and they fail to get better, then at that point we begin to say we may have to do more. The most common step when we decide that we want to move forward is to get an MRI of the shoulder. And this helps us look at what quality of the muscle there is, how big a tear there might be, what other associated problems may be going on and helps us plan the appropriate approach for that patient. Once we've made a determination that there may be a significant tear in the tendon, we would discuss with the patient the potential for repair. In most cases, we're trying to take that tendon and sew it back down to bone, but occasionally we also are sewing tendon to tendon to try to get that rotator cuff put back together. At that point in time, we use our arthroscope or microscope. It is an operation where the patient gets a general anesthetic. Anesthesia frequently talks to the patient about numbing things up a little bit to try to help with postoperative discomfort, but the patient does generally go to sleep. And then we do our repair and the patient wakes up in a sling. Time in the sling depends somewhat on what we have to fix, how old the patient is, how big the tear was, what was the quality of the bone, etc. But it generally is at least a 4 to 6 week window, and they're not doing a lot. We may start a little bit of early motion, but there's a long period of protection in the sling. And then when they start regular motion, active motion, beginning to put the arm up in the air, we have to be careful during this period of time. We can't put stress through the shoulder, so there's no pushing, pulling, etc. The physical therapists help guide the patient along this process. But the patients have to know that it's a long time for them to be able to get back to what they would say is normal function. And we might say it's going to be a minimum 4 months, many patients 6 to 9 months. And so patients getting ready for rotator cuff surgery have to really give thought to the fact that unfortunately this is a procedure that really takes a significant period of time to recover. And we do everything we can to help with moving it along and trying to make it so that it's as tolerable for the patient as possible. But a real reality is this is a big limitation where we take the arm away from you, keep you in a sling, or tell you that there are certain things we don't want you doing for a big chunk of time. And that's something that you have to come to grips with to maximize the chance that you have a good healing period afterwards. Now, an unfortunate reality of rotator cuff repair surgery is that a few of the repairs don't anatomically heal. And so no matter how they're done or how they're protected, some of these tendons fail to heal. And so on a subsequent MRI might appear to still be deficient. Fortunately, most patients feel much better during this period of time, even if their rotator cuff is not completely healed. And so a lot of the pain can be gone, and the perception is they're doing very well, even though maybe at some point a subsequent MRI might show a defect. But patients need to be aware that certainly all the studies done, there's a not insignificant percentage of people that simply don't heal as perfectly as we would like them to heal. So we're part of your team, and the therapists are part of your team, and we certainly all work together with you, but need patients who are about to undergo rotator cuff surgery to know that it's a big commitment on their part in some immobilization, in time, in inability to do some of the activities that they want to do. And so as a team, at the end of the day, we hopefully come out with everybody feeling a lot better. Now, this has been a fairly brief video about rotator cuff. It's a very complex topic. Certainly, we can't cover all of the issues involved with management of rotator cuff injury and surgery. The risks, complications, even some of the rehab can vary for patients. So this is just to answer a few basic questions, but this is clearly an in-depth discussion with your surgeon.